Hello, everyone, and welcome to this webinar sponsored by ASPA's section on democracy and social justice, dismantling inequities and injustices in healthcare and public health, which is part 5 of DSJ's series on dismantling white supremacy. This event lasts until 2:30 p.m. Eastern Time. It is being recorded and will be posted later to our social media channels after we review the copy with our panelists. My name is Sean, and I serve as chair of the section, and I'm joined by Parisa, who is our stellar digital engagement coordinator for the section. And we're going to be remaining largely off camera for this event, which really just makes editing the video easier. But before we get started, we'd like to let you know about a few other DSJ events that are coming up. So first, for the third year in a row, our section is proud to co-sponsor ASPA's Social Equity, Diversity, and Inclusion, or SETI workshops. On October 1st, we have RaJade, Dr. RaJade M. Barry James, who's also on this panel. We'll discuss conducting SETI research, why research matters. We'll be sending you a couple links, RSVP links through the chat. On October 8th, Dr. Meghna Sabharwal will be discussing creative inclusive workplaces. On October 27th, Dr. Stephen Patansu will discuss integrating SETI into missions, plans, and performance management. And on December 9th, Dr. Richard Gregory Johnson III will discuss weaving SETI into curricula. So again, we'll be sending you the RSVP links to you shortly, and hope you're able to sign up for all of them and join us for all of them. Then the next thing to let you know is that on October 13th from 1 to 2:30 p.m. Eastern Time, I hope you're going to be able to join us for a discussion of voter rights in election 2020. This event's going to be moderated by Dr. Carla Eljevikovich, and it's going to be featuring these 6 amazing panelists. And we're going to be discussing lots of different topics from disenfranchisement, the equity dimensions of election 2020, voting patterns, voting rights, and much more. And both during and after that event, we're going to be sharing several resources on voting rights and procedures. And again, we'll be sending you an RSVP link to that. And we hope you're able to join us for that discussion as well. So without further ado, let's get to our event. So we're proud to be joined today by 4 amazing panelists. We have Dr. RaJade M. Barry James of the North Carolina State University. We have Cynthia Golembeski of Rutgers University-Newark, Dr. Vanessa Lopez-Littleton of California State University, Monterey Bay, and Dr. Carla J. Sampson of New York University. And this is an especially timely workshop webinar because healthcare and public health have been prominent areas in which racism, white supremacy, and patriarchy manifest. And the ongoing global pandemic, among many other current situations, make dismantling unjust systems a priority. Lives are on the line, and we must act. So some quick logistics. We'd ask that everyone who is not a panelist to please just turn off your camera. And we've just found that this improves the quality of the speaker's audio and video. And then after opening Q&A, we're going to have a little, it's going to be round robin Q&A questions we co-developed with our panelists. And then we're going to open up to audience Q&A. And if you'd like to ask a question or make a comment, please do so in the chat. So I'm going to stop the screen share right now, and we can go ahead and get started with our first question, which I will be posting shortly into the chat. One moment, please. So our first question to all of our panelists, and please just feel free to go in whatever order you would like. What is an area of healthcare and our public health that you have researched in which racism and white supremacy are evident? And what are the causes and effects of racism and white supremacy in that area?
So
Dr. Barry James.
Guys. Oh, go ahead.
Oh, thank you. Well, Vanessa, did you want to start?
No, absolutely. You were called on, so I'll let you have it.
Thank you so much. Well, I just want to say thank you very much for having me today. I appreciate the time and space to share some things. I have in the past, 20 years or so, worked as a disparity researcher, mostly in community health. I like to tell people that sometimes I share my time and talent, my superpowers, if you will, as a program evaluator. And what that does is it takes me into the community to do real work that matters. And so while I was living in Ohio for about a decade, I worked with the Akron Community Health Center there as an evaluator of the substance abuse treatment programs that were there. We worked in 3 areas. One is with targeted capacity expansion grants. And so I work with women who are living in public housing and experiencing some AOD issues, helping them to maintain their sobriety and move on with their lives to help better themselves and their families. I also work with HIV positive minorities and those who are at risk to contracting or living with HIV. And so the folks in the Gatehouse program, as we belovedly call them, they were also suffering or experiencing substance abuse. And so we work with them on some treatment protocols, that kind of thing. And then the last group of people that I work with during that time is adolescents through the Effective Adolescent Treatment Program. And so there we worked with cannabis users or young people who were smoking marijuana very early on in their addiction. And one of the things that I realized in doing that work is that it's sort of a calling. It's a calling in that you recognize how important that stakeholder group is. It was really a developmental process for me as a professor. What I did, of course, working first with TCE Women in Public Housing, what we realized after the first year of evaluation is that there was another group that needed to be served, mostly adolescents, children of women who live in public housing. And then the other thing we recognize is how important it is to mind the gap, that in fact in that community during that time, there was a gap in service for people who were of color and also HIV positive and also experiencing substance abuse. And so I think that, that time period personally and professionally was probably the best time of my life, in that I could use my time and talent and help people exactly where we find them. I think working with a community health center in that context is really important because you understand the competing needs of community. The community, Akron, Ohio had the same problem as Cleveland, Ohio, and other surrounding communities. However, making sure that we bring resources into those communities and establishing programs to help serve people where we find them, really important work.
So thanks, Jade. I guess I'll go next. I was thinking about kind of responding to this in a lot of different ways. And what I landed on is my background is so varied. I started off my professional career as a soldier in the United States Army. And then I became a registered nurse. And then I became a nonprofit executive, even spending time as a presidential management fellow at the CDC. And so now I'm in education, and I feel like my career has come full circle. I think a lot of my research started back in 2006 when I started working as the executive director of the Seminole County Healthy Start. And we had one clear mission, which was to help women have healthy pregnancies. And so it was around that time, even though I was a registered nurse and I'd even done maternal child health nursing, like I worked with women after they had babies, I never really knew that Black women were more likely to die in childbirth. I'm from Louisiana, and over the past couple of years, I've come to learn that the infant mortality and the maternal mortality rates in Louisiana and across the country are just abysmal. And it's this kind of realization that helped me to understand what my true calling was, and that is to improve the lives and livelihoods of folks who suffer at the hands of just a system that disadvantages folks. And that's the reason I'm really excited to be a part of this panel, because I've been talking and thinking in the space of systemic racism for a while. I never called it that. I didn't name it that, but it's been something that I've been, kind of grappling with for a while. And so over the past couple of years, I've had this opportunity to start researching and understanding some of the reasons of why these differences exist. And I even like thinking about, like, people always say, well, why are Black babies dying at such a great rate? And then after they ask me that, there's almost like nothing there. Like, even if I tell them, it doesn't inspire them to action. And I think that's, to me, the most disheartening thing about focusing on infant and maternal mortality. And so, like I said, since 2006, I've been and working in this space, working with community-based organizations to try to drive change in communities, and now working in education or in academia, trying to study, research, do all the things that we can, but there are some things that are just lacking. And Carla, who's also on this panel, Dr. Sampson, she's going to talk about this as well, because we last year we did this study in Louisiana where we were looking at infant and maternal mortality rates in that state. And one of the things that one of the big takeaways for us is that systemic racism is real, and the manifestation of that system is the rates that we see, where Black babies are more than 2 to 3 times more likely to die than white babies. The fact that Black women are 3 to 4 times more likely to die, from maternal complications than white women. That's evidence that there's something wrong with the system. And when we continually put this back on the individual to say, well, I've heard things like, well, it's a vitamin D deficiency, it's genetics. If it were actually that simple, we would be able to address the problem. And here's the deal, when we're talking about race is a social construct. It's not a genetic, condition, or it's not something that we say that these are, genetic issues and we can isolate the gene and then we can, either eliminate it or enhance it or something. So that's not what we're talking about when we're talking about race. Race is not something, I don't want to say race is not real, because it does have very real social and political implications. And so I'm going to stop my talk there because I can keep going. So I want to honor my other panelists and let them kind of weigh in here.
And so I can go next, Cynthia, and thank you for inviting me to be on this panel. So I come at this from a slightly different perspective than the other panelists that you've heard before. As an adult immigrant from Trinidad and Tobago, not saying that we have all these race problems figured out in the Caribbean, we have different problems, they're really about class and color. I kind of interrogate American history and American healthcare system from that lens, understanding some of the words of Dr. Eric Williams. It says, okay, the political and moral ideas of the time really are to be examined in close relationship to economic development and sort of follow the money, and that those things still persist long after we destroy these systems. So with that perspective and lens, I back-ended into looking at the effects of race, particularly on the social determinants of health. Because I know that the American history is problematic, but here we have a system that is built on the idea of that Black bodies are at the same time fearsome, superhuman, yet they're somehow inferior and indispensable, and how that is manifesting throughout all of the systems that we have built. So I became fascinated by that, because if you think about the models for social determinants of health and you think of everything that can affect your outcomes, undergirding all of that and not yet said is that race and structural racism undergirds it. It is, but it's still not explicitly included. So we can look at all of the horrors recounted in some of the literature, such as looking back at Killing the Black Body or medical apartheid, but all of those say something that we're still not yet ready to say, that the effects of racism shows up in health outcomes. We talk about it explicitly when we talk about maternal health outcomes. We talk about it in terms of infant mortality, especially of Black infants. But it is the same, we can pretty much paint the same picture for every aspect of Black life. And this is something that I've been looking at more and more, particularly with an angle looking to how we can develop policy around our US healthcare workforce.
Fantastic. Cynthia.
Thank you so much again for allowing me to be here with such amazing panelists. So I think I started out mostly working in the nonprofit sector and then academia. and I'm trained in public health. So Nancy Krieger suggests that public health equals social justice. So I sort of came of age really trying to understand why there were so many inequities and disparities. And I work primarily with folks that have direct contact with the criminal legal system. So I work for a reentry nonprofit in New York City. And then I also work, currently I've been teaching in the New Jersey state prisons. And that's actually part of Obama's support of a pilot second chance Pell Grant project, which we might recall how Pell Grant eligibility has been removed from folks who are incarcerated. And I remember being very young when New Jersey voters really supported taking those rights and funds away. And so I think fundamentally, as we know, there's amazing work around hyper or mass incarceration. And I think the intersection between public health and the criminal legal system is very salient for a lot of us in terms of understanding how so many issues that could have been addressed through a public health approach, or one that would aim to heal, ameliorate suffering, or help people even with material support so that they could thrive. Instead we used a system or supported a system of punishment, and now I think everyone's paying the cost. But this could be traced back to historically thinking about partial feminism, where majority, a lot of white women really jumped on the bandwagon to use a punitive approach to address things like sexual violence or intimate partner violence. So I think historically there's a lot to learn, but like those that have just spoken, I really have learned much in terms of understanding how structural racism and I've also heard people include economic deprivation as part of that. But with structural racism, Zinzi Bailey and some of our authors, they define it as referring to the totality of ways in which societies foster racial discrimination through mutually reinforcing systems of housing, education, employment, earnings, benefits, credit, media, healthcare, and criminal justice. And so I think with that said, echoing another panelist's emphasis on the social determinants of health, there's so much that influences health outcomes. And lastly, I just want to reference Ruha Benjamin and people like Monica McLemore in public health and related fields who are urging folks not to just look at race as this category or categorical variable on the X or Y axis, but to meaningfully think not just as race being the risk factor, right, for health disparities or negative health outcomes, but to really look at racism itself and structural racism. And then I think, again, for myself and other colleagues, how are we really invested in and propping up, the system that causes so much harm, even if we think, we're helping. So thanks.
Wonderful discussion. Panelists, do you have any other follow-ups to something that another panelist said or additional comments you would like to make? I got to tell you, these initial comments already inspired some questions that we received through the private chat, but we'll hold them off for a little bit. We already received two referencing this, but any follow-ups? Dr. Barry James?
Sean, I think it's just really important for us to really talk about, what white supremacy, how we define it, right? I think concepts are really important. Just like we said, that race is a social construct, right? It's something that I think the American Psychological Association has said we've done more harm than good, using and focusing and emphasizing on this kind of construct, right? Especially that we haven't really solved the issue of sort of the disparities that exist among racial, ethnic, and cultural groups. But I think from a white supremacy point of view, for me, I just anchor it in that, something that I don't even identify with. I know that it's there, and I know that it sort of drives the way in which we identify problems and also suggest solutions. But, it's just sort of belief that one group of people, white people in particular, are superior to all other races, but especially to the Black race, that and therefore white people should dominate in a society. And so when we look at healthcare and the healthcare system without minding the gap and identifying disparities that exist and using that point of information to really change everything else we do, I think we do in fact support or sustain this white supremacy kind of perspective with respect to health and healthcare. I wonder what other people think about defining the concept and where we stand currently.
Fantastic.
Yeah.
Yeah.
Thanks, Jade. I want to jump on that. Yeah, so this, when I first saw the topic about white supremacy, and I was thinking, okay, so this is going to be controversial. And so what I began to do is to start thinking about, why is it controversial? Why, when we use the term white supremacy, does it become controversial? And here's what we know. We know that in the United States, as of right now, that whites are the majority population. We also know that as of right now, whites have the majority of social, economic, and political power. And so with that comes opportunities where, if you look at Fortune 500 companies, who's running these companies? If you look at the United States Senate, who's the majority in the Senate? So when you look at a lot of the economic, social, and political power bases within the United States, they are predominantly manned by white people. And I use the word man, not to throw shade at women, but that's where we are as a society. And so I feel like this is such a necessary conversation to begin to have, because what people like to do when they hear a term like white supremacy or even systemic racism is they like to focus at the individual level, to say, like in their heads, they're thinking that these are individual people perpetrating individual acts. And so they push back against that to say, well, there's not a whole lot of these racist people doing these racist things. But that's not what systemic racism, or even what I've learned white supremacy, is actually about. What it's actually about are how various systems, public, private, nonprofit, educational, all these systems, how they coalesce to create differential outcomes, whereby we are structuring opportunities that disadvantage some groups of people while simultaneously advantaging some other groups. And it is so poignant in healthcare. So if you look at the health outcomes of white folks and you compare those same health outcomes to Black folks, you will see inherent disadvantages. These are not merit-based systems or outcomes. These are things that are related to the way in which the systems are structured. And it's not just in policies, it's also in practices. A lot of the things that we see are not codified into law or not written into any kind of policies. These are just the way that things are done. And I'll make one last comment as it relates to maternal and infant mortality. It's interesting to think that there's so much data that supports the notion that Black women deliver babies in hospitals and other facilities where we know that they're more likely to have a negative health outcome. And the most interesting thing is, for the most part, white women don't deliver in these same institutions. And so I'm not suggesting that we just shut down all of the poor performing institutions, but what I am advocating for is that we do have some system of accountability, and that takes leadership and that takes ownership of this notion of systemic racism. And as of right now, we've not seen that type of national leadership or national strategy to address these health disparities, yet we've known about them for decades. And so I'll end my comments there. Other folks?
Fantastic.
When I think about white supremacy, I think about how it really has sort of hard-baked ideas about people of color, especially in America. When we think about white supremacy and we think about how they think about Black people, especially when it comes to healthcare delivery and actually the profession of medicine, we're really talking about the ideas that really say to us as Black and brown people that because you are deemed inferior, we have a different way that we should treat you. And this manifests in the way in the interaction with medical professionals, where you might get screamed at, where you might not be believed, where you're just deemed non-compliant, something that we just wrote about. But also it is used to rationalize our current health status and our socioeconomic conditions, as just because you're Black and Latina, you have these outcomes. Nothing more else should be added to the pot. This is just the condition of being Black. And this is not fair to us. And I think that's some of the ways that we see this manifesting in it. And this is how this has been allowed to continue for so long. So I think today we're starting by calling out some of the things that we need to start working on.
Fantastic. Cynthia,
Yeah.
please.
Right. Yeah. So I think I find what's being discussed is really powerful, and I do think that white supremacy has been proven to be a lethal public health issue, as we've seen, due to COVID, police murder, and violence, and it is something that I think a lot of people have not wanted to discuss. But I was really struck with what was suggested in terms of thinking about practice as well as policy. And so this idea, again, I wish I could say all these amazing ideas, but I'm going to reference other people, of course. So Helena Hansen and Jonathan Metzl, and Metzl often works with Dorothy Roberts, who was referenced earlier. And, so she's really done this amazing work as a trained legal scholar in how child protective services, right, really do disproportionately affect Black families and mothers and children negatively, right? And there's a lot of criminalization. And then Metzl, he did this amazing research around the 60s where when there was a lot of political protests, Black men were actually being disproportionately diagnosed with schizophrenia. So again, I think, what's been said, there's this historical proof of these disparities, but as folks just said, it's not because of these individual characteristics, it's how the structures are pathologizing or choosing to treat or not treat, and then again, these structural matters. So what I like about Metzl and Hansen is they suggest that we don't look only at cultural competency. So I, as maybe a white woman training in public health or medicine, I want to understand what is an Asian American woman's understanding of her health around a particular issue. But it's more like infusing clinical and perhaps even policy training with structural awareness and moving beyond cultural competency to see how these structures, which I'm a part of and a lot of us are a part of, produce these health inequities. And so I just think, again, there's this movement to shift, but it is something it seems that a lot of folks of color, women of color are really leading, but then also it has been presented, I think, since the 70s or earlier. But again, just I'm shocked how sometimes I'll read something from decades ago where it's basically saying what we already know to be true and what a lot of people contend with on a lived experience. And yeah, I think whites, as Jonathan Metzl suggests in writing about poor and working class whites, specifically those that did come out to support Trump. I mean, 53% of white women in the last election supported Trump, but how they're, these poorer whites in these counties are really voting against their own worst interest. And this politics of racial resentment is also killing whites, right? And so I think, this kind of false consciousness of not aligning around equity, is really destroying everyone. But I think, I think whites need to work really hard to dismantle and also step back and give space to others who have been doing this important work. And as we've all said, it's something that's not popular to discuss, but I think more forums need to discuss it, or else we're never going to be able to address it. And I'm, thankful for a lot of these scholars that have and practitioners have given language to what we've all seen and know, but maybe some of us were uncomfortable, in discussing.
And, and just as a little bit of background here, I mean, I'm just reminded of Susan Gooden's fantastic book, Race and Social Equity, where she says about the need to name, blame, and claim, that we have to name these inequities. We have to be very specific about them, identify these causes and effects, but then also really make agencies and policymakers accountable for actually giving substantive improvements. So this was a fantastic conversation, and we're going to loop back to these ideas again, especially in the context of COVID-19, because we've already received a question about how these are manifesting given the election, but also the pandemic. So with that, let's actually go to our second question. I think nicely really builds off this first. I'm going to put it here in the chat. So again, in any order you'd like, what is a promising strategy to dismantle racism and white supremacy in the area you noted, or in another area that you might think about? Dr. Barry James, would you like to go first since you went first last time?
Sure, Sean. I'm happy to. As you know, in one of the books that Susan Gooden has edited with Kristen Norman Major, we talk about cultural competence and how important it is. In that particular book, I have a chapter on cultural competency in healthcare, which really grows out of the work that I did while I was evaluating programs in community health. And so in that chapter in particular, we talk about sort of some of the things that have contributed to health and healthcare disparities. And some of those factors are really important to note and mention. They include social and environmental factors, as well as system and policy factors, individual factors. And then the fourth factor is really provider factors. And I think that from our conversation, from the contributions of other panelists today, we want to zone in on the fact that providers, people who are in the business of caring for others, right, who understand more so, I think, than many other people, really understand that there is something that you need to know. There is some attitude that you need to have. There is some practice pattern that you need to watch out for. There's a way in which you need to communicate with your patient. And more importantly, there's this sort of demonstration of cultural competence that doctors, nurses, and treatment staff have to have. And when it's not present in the care of individuals, when it's not present in the care of communities, when it's not present in the care of groups of people, the truth is we see some disparities or differences in outcomes, right? I think about all those experiences that I had having children and raising up my own children, and the incompetent care that I've also received, and the difference that it makes, especially when people acknowledge that, well, you're this type of person and you may have this type of care. So I'll just give you a quick story. I could talk forever, but I'm not going to do that. When I was pregnant with my first daughter, I was insisting that I have a pregnancy test so I can start prenatal vitamins. And the doctor's office was insistent that I not come in until after the first trimester. And I was insistent that I come in and start my prenatal care. And once I got there, I took my friend who was a surgeon, and she and I went there, and we were so excited. I was having my first baby, advanced maternal care, advanced maternal age. And what she said to her colleague, another nurse, was, "Oh yeah, she's right, she's pregnant." And then the other nurse said, "Oh my gosh, I hope she's not on welfare." Right? It is clearly a situation where care is somehow connected to these social determinants of health. But then how do you reverse that system? What can we do, given that it is clear in lots of societies and many communities and in households, right, that this thing called racism and this experience that we're having really influences our health outcomes. And so I've been looking at, I don't know, maybe for a long time now, some county health rankings data. It's really easy to find. These data tell you a little bit about, how healthy communities are and what opportunities there are for community members to be healthy in the future. And I kind of live my life under those health factors. What are the opportunities for community members to be healthy in the future? Because I think that policy and programs really rest there. Certainly looking at the examination of gaps, right, is something that I almost always do as a disparity researcher, looking at the evidence that currently exists, whether or not the evidence is credible. Also, looking at evidence that really tells me something about how well groups live and how long they will live, and then really trying to find or identify ways to develop and implement solutions to particular problems that I see. I think that that's a first start. It's definitely a way in which we systematically address some of these issues. And of course, sometimes when that doesn't work, when there's no rhyme or reason for change, we could also just jump right on in and be community engaged scholars. And so right now I am evaluating, I told you that was my superpower. I'm evaluating a farm to early child care and education initiative where it's focused on system change, really training people who need to know the information, really going into communities and providing resources and support as they need it, and then monitoring sort of the changes that we see in order to do more or do less, but definitely help always. So that's just some thoughts I have initially.
Fantastic, thank you.
So I seem to be second behind Jade, so I'll fall in line. Yeah, so it's interesting to think about dismantling racism, something that we can't even agree that it actually even exists and to what extent it actually exists within our society. So I'm going to take the jaded approach and I'm going to say, I don't think that there are any real promising strategies, but I do have some degree of hope. But I think what we need is a national strategy. It's interesting to think about as a critical part of this discussion, if we're talking about dismantling systems that perpetuate disadvantage, you've got to begin to think to yourself at some point that if the shoe was on the other foot, if white folks were dying at a disproportionate rate, how would society respond? What would we do? How would we behave any differently, would we? So I think about Dr. Kamara Jones, who's been doing work in racism in public health research for at least 2 decades now, when she first wrote one of her papers on institutional racism in public health. And in it, she talked about the different levels of racism. She described what racism was. And I love how she kind of left it by saying, asking the question, how is racism happening here? And then strategizing and mobilizing to act once you've identified it. We seem, as a society, not able to identify the fact that Black people are dying at such a disproportionate rate as a problem. I think about something that Malcolm X said in thinking about Black women and saying that, as Black women, we are like one of the most disrespected groups in America. And I saw somebody made a comment on social media about it. He put the whole quote in there. And I was like, as a Black woman, I feel that. I'm sometime in leadership positions and I have people respond to me in a way, and I'm always thinking, if I were a white man, would they respond to me in that same way? I don't know, and I don't have any evidence of it, but in the back of my head, I doubt it. And, I worked very hard to get where I am, and the level sometimes of disrespect, of blatant disregard, it's some of my favorite words, it's shocking and appalling. So I'm struck with this thing about, promising strategies. I think about even the group I worked with in Florida that we were trying to help women have healthy pregnancies. And there are other longstanding organizations within the United States and we spend billions of dollars within these systems. In particular, closing gaps, eliminating gaps, reducing the gap, and it's not working. But those people who work within those institutions continue to make their salaries, and they've got some very good salaries. Even folks in academia, sometimes we get grants, and we continue to get grants, and we continue to get grants, and things don't get better. But there's no accountability within any of these systems. And so what I'm hung up on is this notion of the need for a national strategy. And so we can't have our elected officials rejecting the notion of systemic racism and that be okay. I mean, this is not a Black people problem. We don't need Black people to speak out. We need our allies. We need other folks to mobilize and strategize to act along with us. And I keep focusing on Black people because that's where my research is, but it's not just Black people. It's, Latinos, it's women in comparison to men, it's indigenous populations. So that's just my particular frame of reference. I think that there's a lot of groups who are disadvantaged historically and currently. And if we're not careful, we're going to continue on that slippery slope. What we've even seen is that in some of these areas, the level of disadvantage between whites and Black people, it's actually growing. It's not decreasing. We're spending billions of dollars, but we're not getting good results. And so when I'm, grappling with this question about promising strategies, I'm like, dude, if we don't have a national strategy, we're just like, we're teeting around the edges. We're not getting to the problem. I'll tell you one quick story, then I'll turn it over to my colleagues. But, I had a sister, I have, she's still here. I have a sister who recently went to the ER. And when she went to the ER, she told her doctor she told her nurse what was happening with her. And her nurse said, oh, I know exactly what's going to happen. She told my sister, the doctor came in and said, oh, it's something else. Changed the course of treatment, gave my sister a shot. My sister went home. Guess what? The next day, she's having the same problem, no relief. And so when I was talking to her, I said, you should call the ER and tell ask for the chief, whoever's in charge, and talk to them. And so she did. And the person was like, oh, you should come back. So then she goes back, and guess what? They give her the treatment that the nurse had suggested anyway. So I'm not pitting nurses against doctors. That's not what this comment is about. This comment is about a failure of healthcare providers to listen to Black women. Even when we're educated, my sister is one of the most smartest, most articulate, most thoughtful, conscientious person that I know. So I have no doubt that she clearly told the healthcare providers what was happening with her, but they didn't listen to her. He found out what her history was, the fact that she'd had surgery, and so he just had his own ideas about what type of treatment she should receive. And so we have to develop a better system that, is not going to be okay with Black people dying at such a disproportionate rate. Mm.
Yeah, and I could follow up right on that, because really almost a similar message of doom, but sort of distant hope. Sounds like 2012. But I don't think there could be just one national strategy. There has to be a combination of sustained strategies at a national level to upend these systems that are really now hardwired after the 400 years of operating on these kind of beliefs. If you were to push me to pick a single strategy, especially in light of my colleagues' comments about their own interactions with the medical system, and perhaps I should tell you my story. In the last 10 years, I have had 2 different doctors look at me and tell me that, oh, because you're Black, you will heal faster, or because you're Black, you will not feel pain, so you don't need any pain medicine, right? So that leaves me with a sort of mistrust of the system, even though I do study the system, work in the system, and think about what else are they thinking about or talking about or being trained to do in medical programs. So that's where I landed on thinking of a strategy that will help us at the point of healthcare delivery. And that is that we really do need more Black and brown doctors. And if you think back to the seminal IOM report about racism and unequal treatment in healthcare. In that report in 2003, even though Black people, and again, I center on Black issues, even though the Black population is about 13% of the US population, only 3.3% of doctors then, back in 2003, were Black. Now, almost 20 years since that report, we've only moved the needle in terms of the percentage of Black doctors from 3.3 to 6%. So something else is at work. And so even though I'm saying that we need more Black doctors, I am not at all suggesting that we need a system where we have Black doctors see Black patients or brown doctors see brown patients. That is exactly not what I am saying. I'm saying that we need to change these troublesome practices by upending the medical education system so we can have more inclusion in medicine, but I know that that would not be very easy. Black medical students face many challenges, much as we have faced in academia, where we don't see the mentorship, we don't see the belonging. Medical students, there was a report recently saying that Black medical students feel social isolation in medical schools. They experience higher rates of implicit bias in terms of the language that's even used to describe their competency, which is very necessary for them to progress through the training. And so they're dropping out. In addition, there was another report, I think within the last year, pointing out that the Medical Honor Society is stacked against all minorities in terms of getting that prestigious honor, joining the Honor Society, and then moving on with your medical career. So I think that's one area where we can use explicit anti-racist policies within medical education. And of course, I'm not leaving out the nurses in this, so that we can get to a place as we thought we would get when this report came out 20 years ago. One of the ways that we need to do that is to diversify medical school leadership. As we look around the halls of people who have been chairs within departments, the number of people of color that you see are few or none, right? And so to do that, we cannot have the few Black medical faculty that we have also be the mentors for the students coming through and also working actively to dismantle the system. They'll be exhausted, right? They can't do everything. This really needs a concerted effort from all faculty in medical schools to understand that there is a problem. We have been perpetuating systems where we have particular ideas about how we should treat people of color, and that is wrong, and we need to work to fix it. And that goes beyond putting nice statements on website. The work needs to happen.
Fantastic.
Yeah, all of what has been said is very powerful. I think in thinking about the criminal legal system, there's been a lot of amazing work in PA, particularly around policing, and I'm thinking of Andrea Headley's work. Also, I was reading some more recent work that she co-authored with James Wright II, and so I know he's looked at how residential segregation is associated with police stop decisions, and then I think they looked at both gender and race in terms of police use of force, and then we talk about accountability, and I know they also look at the role of cameras, and I'm no expert in the area, but I know there's a lot of mixed evidence. And then just thinking recently, I know Dr. Farnbury co-authored a PAR article on social determinants of health, and Dr. Gaynor as well. And so there's just, I feel, and again, the panelists here, I know for P8 Times, and the most recent article on equity I saw with quite a few PA scholars, with RaJade as the co-author. So I feel like the work is really powerful in PA, and it's a space where there's this attention. But I think one thing, in kind of the thinking about the criminal legal system, it's interesting because policing is really important, But an area that I'm modestly working on is around bail and bail reform. And so I think people have thought about the criminal legal system in terms of trying to understand this more as a continuum and sort of a very processual system, right? So we have many laws and many actors. So there's the police, but there's also the prosecutors, which are 95% white males. And although there are progressive prosecutors moving forward, who, not surprisingly, are a lot of women of color in major urban areas. There is that shift, but it's sort of like who's going to want to be the prosecutor, and then also just in terms of just the barriers they face, just seem intense. And then we think about judges, and I know there's a lot of more work around these judges not coming just from these top Ivy League schools, but then also, yes, being a part of this literal old boys network. But in Colorado, I saw there's this recent appointment of quite a few Black and African-American female judges. So there's just these spaces of hope, but I think it's so disparate and patchy. And I agree with what was mentioned, how I feel, with modesty, there just needs to be a radical restructuring and rethinking. And I think Ruth Wilson Gilmore poses the question, do we even need prisons? And abolitionism now is something where it's becoming a part of a larger discourse within public health. And just thinking, when we think about bail, we're one of the only countries that has cash bail. And fundamentally, we know the criminal legal system is racist, and there's so much data to support that. So it's really difficult to even suggest it's not the case. And then we look at public defenders and how they're overwhelmed and overworked, and just the resource disparities for poor folks of color navigating this system. And again, just it seems like every interaction they have, whether it's child services, even social work, or probation or parole officers, it's just the odds are so against one. And then even the healthcare system within these prisons or jails. So I think it just can be really overwhelming. But again, kind of radically restructuring and questioning, why do we have bail if it's for public safety and it's to make sure people come back to court to appear. But we see other evidence from community bail funds, a lot started in the Bronx, where people are appearing without the need for bail. And so it's just such a, racial capitalist tool, as we see with a lot of the private actors benefiting from the criminal legal system, but also with the health system too. And I think just lastly, in thinking about accountability and public administrators and providers, but also the bureaucrats that we are or might be and who we might study, Homer Venters took over Rutgers jail system. And what's interesting about him is he actually was trained in not just trauma, but torture. So he looked at torture, people that experienced torture victims, if you might, at Bellevue Hospital, right, which is a public hospital in New York City. So when he came to Rutgers, he just saw, painfully so much in the way of how this site was a site of torture. And he saw, boys come in and leave with traumatic brain injury. He saw people in solitary confinement having high rates of self-injury. And then, corrections officers would have injuries that reflected a use of violence and force against these men and women and even boys and girls in these jails. And so I think what he tried to do was implement an electronic health record system that would help track what was going on, so then it could be analyzed. And just very briefly, that one, they co-authored about 40 articles just documenting all of these health concerns and constraints, but then also what he terms jail or even prison attributable injuries or deaths. So that means if you didn't go into the jail or I didn't go into the jail or the prison, we would have never experienced that injury, illness, or death. So, people have been in extreme temperatures, right, while they're confined. And we know with climate change, poor folks, people of color are even more adversely affected. We know, again, a lot of violence perpetuated against folks that are incarcerated, and then things like sexual assault, where there is PREA, a system where they're supposed to be reporting, but it's very complicated within such a space. And he terms it a paramilitary space. So then you have these healthcare providers that are also in jails and prisons where there's high rates of illness. And again, not because these people come in and they are ill people, but because of, again, the structural barriers and inequities that impose illness upon them literally. And so I think that that's a little sliver of how, you know, there is some increased understanding, but I think the movement's so slow, and Rutgers is closed and largely in part from people directly impacted who did share their experience and their expertise, but it's just so out of line with what needs to be done, you know, at a larger scale. And I think, you know, Rosenblum and O'Leary talk about prisons as closed systems. And I think there's no secret that there's no accountability, there's no transparency. Just very briefly, like with COVID and prisons and jails, like we often have no idea what's really going on. And then finally, some prisons and jails are reporting and they have these dashboards, but some of the information is not accurate. So we had actual folks at places like UCLA or another public health practitioner take it upon themselves to try and actually comb and basically collect this data. Even the New York Times is one of our reliable sources for looking at these COVID hotspots. And it's no secret that they're in jails and prisons, nursing homes, particularly those housing our most poor, vulnerable, and majority folks of color. And then also the meat and poultry processing plants, which we know it's a lot of our immigrants and folks of color who just, their workers' rights and health rights aren't being you know, honored. So yeah, sorry that was a little long-winded, but I think again, it just seems like we're, after last night's debate, we're just playing catch up. And again, I think there are these systems and structures that are premised on white supremacy. And I think seeing that is important, but then just, yeah, basically pushing to overhaul and again, let others come into the spaces and reform, I think more radically than we, you know, might even imagine.
Thank you. Those are really fantastic comments, everyone. I'd just like to draw everyone's attentions to several comments that have been made in the chat. So Marina Garcia has sharing some information about Duke University and releasing a study. There's also a report that she indicated. What I'm going to do is I'm just actually going to share it towards the end of the chat so that everyone can see it. Also, Dr. Barry James has shared some other information as well. And I'd also like to draw attention to a comment that Kim Golembeski made. I'm actually, it's a little bit higher up in the chat, so I'm going to post it right here. Just posting there if any of the panelists would like to respond to any of the comments that have been made in the chat thus far.
So I'll comment about the comment about Black women. Let's see, it's something about a rare disease. So let me just speak just for a moment about something that my colleagues and I have been thinking about, which is misogynoir and the way that Black women experience healthcare that's so different than other people's experiences. And so I can't necessarily speak to the specific question and the issue that this person may be having in overcoming a rare disease. But I think that our interactions with the healthcare system, you know, from the evidence, it's clear that it's different than how other people experience healthcare. And so because we know that, it would appear to me as a relatively reasonable person that there could be an opportunity for change. And so what I'm wondering is how do we as Black women begin to demand changes in a system that is not, that has demonstrated repeatedly, that is not going to be responsive to our needs? And so I'd be interested to hear, you know, I've been grappling with this for a while and I know what my thoughts are. So I'd be interested to kind of hear how my peers would respond to that notion of misogynoir and the way Black women are experience healthcare, and how we, how do we navigate this healthcare system when the system doesn't appear to be respectful of us?
Vanessa, that's such an important question. It gets right deep down in my feelings, right? When I respond to it, offline, I said my husband's a physician, so I sort of live this medical journey with respect. And often my heart and the work that I do is with people who I just see myself with them, right? I have a special group of people that I work with, not because I have this sort of intense desire to work with these kinds of people, but because I see myself there. They're part of my community, my family, my culture, that kind of thing. But I do remember, as you pose that question to the panelists, I do remember the time where I took my littlest daughter in to a hospital to have some sutures removed from her lip. We had been at a previous hospital an hour and a half away, and they said, it's really important, Mom, for you to remove these sutures on day 7. Otherwise, that material that's holding her lip together will not be good for you and your daughter. And I said, okay, because it was a really important situation. She had a open wound through and through at the center of her mouth, and we knew we had to have it fixed. We drove an hour to a doctor's office with the surgeon to make sure he fixed it for her. And then we went back home, and I went on that 7th day to have the sutures removed. We went to the doctor's office. She had 3 sutures. They had 4 people holding her down, and she was fighting for her life. They were able to get 1 suture out, and the doctor said, the pediatrician said, I just can't, I don't want to do this. I'm going to send you to the suture clinic in the Children's Hospital. We went down there. They took the 2nd suture out, and the 3rd suture slipped in the lip under the skin, and everyone walked out of the room. And I waited because, the kid's mouth is bleeding and such. And someone walked back in looking like a doctor. And I said, so doctor, what do we do? What are our next steps? The suture has slipped under her skin. What do we do? And he, with his back to me, said, I don't know what you're talking about. And I thought, at least 10 years I've been working on cultural competence, and I had 1 baby crying and 1 baby bleeding, and I had to get to the office later that day, and I said, excuse me, you don't have that type of training. You better get somebody in here who knows what I'm talking about. So then another doctor came in, and another person came in, and they said, Mom, we did not see the suture slip under her lip. And I was just thinking, this is a real critical moment for me here. I don't know what to do. So I said, you better get everyone in the room who was in the room initially, and everyone came back. And I said to the nurse, did you see the suture slip under my daughter's lip? And she said, I did. I said, and another doctor said, well, we need you to sign this form to discharge. And I said, no. What you need to do is put on that form what the material is, the estimated length, and the fact that you saw it slip under my daughter's lip before I leave this place. And when I left, and they did, and I signed the form, and when I left, I called my husband hysterical. What do I do? He said, you advocate, you go back up to the doctor's office, the people who referred you down there, and you tell them about your experiences. And I did. And everyone was on lunch break. And I said to the staff person, the front office worker, I don't care how long it takes. I'm going to stay right here with my screaming, crying, bleeding children until someone comes out and talks to me. And they did. The doctor came out and he apologized for my experience. And he said, we'll set you up with a plastic surgeon to see if they can help your daughter. Okay. So we did. And that plastic surgeon said, no, we can't help. Let's just let her lip heal. And then, yes, it's going to cause a scar, but we'll fix that later on, Mom, And so there are ways in which you can handle all types of situations, and we handle it in another healthcare organization, right? And my daughter doesn't have a scar on her lip. Well, I think back about my own personal experiences, and I have a few more not today, maybe at a conference all together, right? But wonder who's minding the gap, right? What are the penalties for ignoring these racial and ethnic disparities in healthcare, right? You talked a little bit about grants that continue to be funded, right? And so we assume that people who are funded in their work are doing so because they're being good work, right? For narrowing, for making it a difference. But then, so if that's the case, right, maybe it isn't the case. We just want to system, right? We keep on doing what we keep on doing because we don't know what to do. So then it's how can people, racial ethnic groups, right? People who are in gap, right? How can we advocate for safe and reliable care? And I think that's a really important conversation to have, right? Obviously, we're going to advocate, right? But I don't know what else to do. I know that when I'm a parent in the situation, I'm being denied good quality care. No matter how much I look it up on my iPhone, when someone in front of me is doing the wrong thing, how can I stop this train I'm on, I think that's such an important space to be in right now. Yeah.
Fantastic. Any of our other panelists?
I just want to say thank you for sharing that story. It was difficult for me to listen to and to be you in that moment with those clinicians advocating for your daughter. And you know how we are as mothers, we are fiercely protective and, like lions. We're going to take care of our cubs, right? And so just thinking about you being able to advocate for yourself and getting the result that you need, and thinking about the other people who may not know enough to do that advocacy on their own. And just thinking about the interesting place it puts us as Black women, where we're already deemed angry, we're already deemed non-compliant. So in that moment, advocating for yourself, you probably, and I'm only saying probably, you probably then in their minds cemented the image of Black women being this particular way, right? And that played out in the media when we all saw that story of Serena having to advocate for herself after her pregnancy, where she was telling them, listen, something is wrong. I've experienced pulmonary embolisms before. Something is wrong, something is wrong. And it's not until she was able to say the test she needed to find what was wrong, they found what she was talking about. And some of the results that we're seeing, I would be willing to bet, are about the fact that we're just not believed, which is shocking.
Yeah.
Shocking and appalling.
Shocking and appalling, yes. Shocking.
But I would like to add a characterization of Black women. I would like to also add that my entire life I've been called aggressive, and I appreciate it, right? Thank you, right?
Yes.
And so in my aggressiveness, I assure you that I demand the kind of clinical patient relationship that I deserve, not just as not as a Black person, but as a person, a human being, right? This sort of human-centered approach, right? I'm the patient and you are the physician or the clinician. And in that relationship, you are supposed to bring your best self to work, right? Just like I am supposed to tell you what's really happening to me, right? But I also think, though, that there are some other things about the healthcare system that's dirty. It could be financing, right? What type of insurance I have. Yeah, I can tell you that that's just not, the way it should be, right? Remember my earlier comment, oh my gosh, I hope she's not on welfare. So what if I am? I used to be on welfare. So what if I'm not on welfare now? I demand the best healthcare that you can provide, right? And so I think that at some point, advocates for others, right? Maybe in our spaces where we stand as advocates for others. We having gone through this healthcare journey, right? We understand that the structure is not what it should be. It's not equal access to all of us. The way in which care is managed nowadays really depends on, who's in front of you. And also the way in which healthcare organizations operate may be unfair and unjust, right?
Fantastic comments. Any further? So we actually did have a third question that we were going to ask, but we've been getting so many great ones in the chat. So I want to propose that we, in our last 21 minutes, that we go to some of them, because they're really getting on some very current thing. We see that Marina Garcia right here has mentioned more about going back to last night's debate. That we had an earlier comment by Julia Curry, SJSU professor, about studying mental health, seeking behaviors, so forth. I encourage everyone to read those, but this was a question that we've actually received a version of quite a number of times in the private chat, and I think it nicely builds off what we're discussing and what's going on in the chat right there. Big question: what is at stake in the current election regarding racism and white supremacy?
Does someone want to start and let me follow up? Let me take it. We'll take Jade off the hook.
Are you sure? Okay.
Yeah, I'll be honest with you. I couldn't watch the debate last night. I watched about 10 minutes of it and decided not to. I'd had a long day, and their communication wasn't as clear as I would have liked it to have been, so that we could really take the time to focus in on their messages. And I think that this is a critical election. I've heard people say things like we're in a battle for the soul of America. I've heard people say that, we cannot allow the continuation of the current administration. But I'll center my brief comment on this. I think all elections have consequences. And I'm one of those people who I think, with politics, we see the swinging of the pendulum. We'll go to one side and then we'll come back to the other side. But what I see happening in this particular election is that pendulum is really swinging. There would be a lot of ground need to have been made up to get back to a level of some kind of equity or equality over on that other side. And so I guess I'm struggling with kind of like the gravity of the moment, but then I'm very hopeful about the future, and I have to be. I think, when people tell you who they are, you should believe them. I think a lot of the things that we're seeing in our current administration is indicative of people who don't value and respect the lives of non-white people. And I say that coming from a very real place. I remember, during the election of the current president, when there was a one Black man in the audience, and he said, "Hey, there's an African-American," and called him, like my African-American. He called out this guy. And I remember thinking to myself, wow, had that been me, how would I feel? How would I, have responded in the moment? I think I would have been insulted. I think about, last night, about the comment he made about the Proud Boys and that they should, stand down and stand by. As a Black person, if I had fear, that would be really scary, but I don't have fear. I have to be brave to do this work, to be in a live meeting talking about systemic racism and naming it and saying these things, constantly writing about it. I don't have that fear. I think about that bloody catalog of oppression of all those Black bodies that lay underground now. I can't be afraid in this moment. We can't be afraid. We have to realize that if we can't make this better for ourselves, we have to make it better for the next generation and the generations to come after that. We have a duty to do that. And so for me, that's what the impetus is. How do I make this better for my granddaughter? How do I make it better for whoever else's great grandchildren or whoever, wherever you are? We it seems like we're just moving in a place where we're becoming more divided. And I remember that slogan, you know, make America great again, where it's a throwback, it's going backwards. And I am not a backwards thinker, I'm a forward thinker. And so I think for me, when I heard that, I'm thinking, well, back to when? Back when Black people were enslaved, back when there were Jim Crow segregation laws in place, back, I mean, exactly where do you want to go back to? Because as a Black person, that history is very oppressive to me. And so for me, I choose to focus on the future. And I'll be honest with you, I have to have that, because if not, if I lose hope, then I give up, right? And what's the use of that if we're actually going to be existing in this society? So I look forward to hearing my panelist comments. And Jade, I know you're ready to go, so I'll stop yapping.
I just want to say that, you know, I said before we got started, how I appreciate being on a panel with you, and how whenever I'm in your space, in your wake, in a space that you occupy, how you center me in a way that's really meaningful. So I'm grateful that we have this time again today. I do, and I told you a little bit that I like to say I'm an engaged scholar, and maybe for some people they don't like that, because I'm always in the world, right? I want to be there, and I want to help, and I want to share what I know and share my time and talent too. And so I've been thinking a lot about my own role. And my role is really based on one that recognizes how research methods matter. It's not just the title of a book that Susan Gooden and I wrote together. It's really about using evidence to make better decisions and teaching that as a skill in the space that you occupy. As a professor, I certainly can go to class and write papers and do those kinds of things. That's expected, right? But really looking at the way in which we collect credible evidence that's used to really improve our social condition, that's really what I'm focused on. I've been looking, I will tell you that since the coronavirus was declared a national public health crisis in America, I have read every single thing that the CDC has put out. And I watched every single day the number of people who died as a result of the coronavirus. And I stopped looking at those numbers every night before I went to bed when we hit 200,000. For me, 200,000 deaths were too much more than my psyche could take. And so I'm starting to think more broadly about community spread and the impact that it's having on communities. In another webinar, I shared some data from the city of Philadelphia, where you're looking at their hospitalizations by race. More than half, almost 60% of the people who are hospitalized in a short period of time were African American. When you compare that to their population, the city of Philadelphia's population, looking at disproportionality, you see that African Americans are disproportionately impacted by COVID in the city of Philadelphia. But that story that Philadelphia tells, the city of brotherly love, where my favorite uncle lived, right? The truth is that story is being played out in every community around the country. And what Black people are seeing, Hispanic people are seeing, is that we are disproportionately impacted by the coronavirus. However, our policies, our programs, our practices aren't pivoting quick enough. And so therefore, we're not using the data that's in front of us, the data that is available to us to make better decisions to save lives. I can't look at how many Black people are lost as a result of the coronavirus, because the totality of the loss, the 200,000 people, they're not just Black people, they're not Hispanic people, they're not Asian people, and they're not white people, they're not mixed race people, they are people, human beings, right? And I strongly believe that we've not done what we should have done on behalf of the American people. The virus did not start here, it came from someplace else, and those people knew what to do, how to pivot, how to change policies and programs and practices, how to get the word out. And I think that we've really lost the opportunity to be superheroes in the public sector, right? To save people. But going forward, we know that that gap, we better mind it. We better look at it. We better examine it. In my meeting yesterday on campus, I said, how many of the students are Black, who have caught the coronavirus? How come we don't include racial ethnic characteristics on our surveillance data or our coronavirus statistics that are on the university webpage? We need to, so that we understand how to pivot, right? We understand which communities need help and when they need help. And for me, that's a real social equity context. Sometimes you can't teach that to people no matter how many tests you give them, right? But you have to be about it. You know, we say, what do we say? We say, talk the talk and walk the walk. Right now I'm walking the walk to make sure that I leave this world better than I found it. Yeah.
Great comments. Any of our other panelists?
Only a quick tag on to something Dr. Barry James was saying about Philadelphia. I live in Philadelphia, so I'm very aware of the disparities that we're seeing around the city. And although we're seeing those numbers in terms of what do we actually do in terms of practice and what should happen, although we're seeing those disparities that predominantly affect our Black and brown populations in the city, if you look at a map of where people can go to get testing, not represented in those cities, in those spaces in the city at all. So you're thinking about, okay, this is affecting Black and brown populations. And we know that Philadelphia is a city that really is arranged around some historical racial lines. We won't talk about where the sundown areas of the city were, but those areas of the city where those people are of the most need are the places where we can't find testing if you really wanted it. So that's just something to tag on to that.
Any other comments?
So really quickly, yeah, I think one thing I was struck by was just, we started out talking about white supremacy. And again, I think there's so many different definitions, but I'm going to turn back to Ruth Wilson Gilmore, who's a Rutgers alum. And she actually got her PhD when she was in her 40s. And she's been heavily engaged in a lot of direct work with communities. And so she's come up with a definition of racism as state-sanctioned or extra-legal production and exploitation of group differentiated vulnerability to premature death. And I think that is so relevant to thinking about maternal and infant mortality rates that are starkly racially disproportionate and very unnecessary. And then another Rutgers alum, Stephanie Jones Rogers, came out with a book in 2019. They Were Her Property: White Women as Slave Owners in the American South. And so I think, you know, it's really an interesting book. And what she offers is how, you know, the institution of slavery necessitated a culture of violence, and white women and girls were a part of this culture, which also, you know, relied on submission, violence, threat of violence, as well as statism, which she suggests white women were not immune, you know, through careful archival and historical research. And I think, again, white folks reflecting and owning our ties to white supremacy and racism and practices today, but with what was mentioned earlier, also not letting other folks sort of do everything and just watch, but also be thoughtful about how one occupies space and not give way to like a white savior complex. And just lastly, you know, I read something again about Ruth Wilson Gilmore, and there's this term abolition and feminism. And so it's Angela Y. Davis, Beth Ritchie, they use this term. And so I just want to leave with this. So this is what Angela Davis says. She says, historically, Black feminists have had visions to change the structure of society in ways that would benefit not just Black women, but everyone. And yeah, so I guess I'll just end with that. And I think we all know that's very true. You know, and I'll speak maybe for white folks in general, and just thinking about things like, I don't know, gun violence or healthcare access for poorer folks, or, you know, any sort of rights-based area where I think taking others for granted, and others who often I find with some of my nonprofit work, we don't like to talk about how we sometimes exploit folks that volunteer from the community, right? And don't pay folks who are doing work that has value and deserves a wage. So yeah, I just think in my little part of the world, you know, I hope to do some serious work. And for me also to work with white folks, to think about how we can undo and dismantle, white supremacy in ways that are respectful, thoughtful, but also not letting all the other folks do the work, in such exhausting and unfair ways, and then benefiting from it.
That's a fantastic comments, everyone. We have just about 6 minutes left, and this has just been such a wonderful conversation. There is one question we'd like to end with. This was sent by Wendy Nicholson. So Wendy, thank you for sending it to us. I'm going to go ahead and post it in the chat right now, and it's a very apropos way to end this workshop, but also link it to what the panelists have been saying, and also the subject of the debate last night. So here it is. This is what Wendy asked. Given the impacts of trauma due to racial battle fatigue, especially on Black women, how do we ensure that, one, we not only reform but dismantle the systems that continue to advance inequities in maternal health care, and two, include mental health care as an important part of maternal health? And I think especially given the points raised in this election and also last night, this is a very, very timely question in so many ways, isn't it? So anyone wants to go?
That's
Dr.
a
Barry,
tricky
sorry, no,
question.
sorry, go ahead.
Dr. Barry James, go ahead.
Oh, sorry, I saw Dr. Barry James on the screen, so I thought she was getting ready to go. My apologies. Sorry.
Well, I'll just say that I appreciate the work. We've been really busy this summer because of the death of George Floyd. His life is the reason for the work. And in all the organizations that I engage, that I share my time and talent with, I will say the Joint Commission, in addition to ASPA's section on democracy and social justice. I'll let you share the statement, Sean, from ASPA, but I will share that the Joint Commission, their stand for racial justice and equity was something that really actually moved me to tears. I think that it's really important that folks own and understand and pledge and commit to sustain a better healthcare system, better than what we have. Sometimes you'll see around the country people advocate for knocking the building down. I don't. I advocate for taking all the beautiful resources in the building out into the community, partnering with folks and collaborating with others to ensure that whatever is in your building, whatever resource really can bring about change, that you share it to the community and you don't have the expectation that they come to you. Instead, what you do is you go to them. We know that there are a lot of people who've been working nonstop on this issue, right? Justice, about fairness. We might call it fostering social equity, right? But I really just call it the work. And so there are many of us who are working on this. Some of us grow tired, right? Others are working on it because we know that our time is short, but we have to get it done, and we have to make it better for all those generations that really come after us. And so I just would encourage you to take a look at the comment from the Joint Commission. I was going to read it, but I won't do that because everyone reads, right? I'm going to put it in the chat feature so that you see it and you understand the reason why so many of us get up every day and keep working, recognize to take care of ourselves, right? Because self is important, and also caring for others, equally important. That's what I say.
And thank you for sharing that, and also sharing the link through the chat, Dr. Barry James. We appreciate it.
Yeah, I know we're getting low on time, so I'm going to ask my colleague, Dr. Sampson, to comment.
I think on the point of, and thank you for that comment, Dr. Barry James. I think on the aspect of the question about the requirement for mental health as a very necessary component of getting us over the trauma, I think that in and of itself is a whole new area of research that demands a lot of attention, especially because we still within our communities view mental health and behavioral health as something that is stigmatized, something that only the worst of us require. And because if we think about cultural competence in this space, somebody who can understand our culture, our lived experiences, we still have those shortages of professionals who we can relate to as mental health professionals and know that it's not something that we could share, particularly in a group setting. It demands one-on-one time with a clinician to work with and get to some place where you have the tools to deal with the things that you've experienced. That is a very open frontier for ways that we can build up the healthcare workforce who have the capacity to address the things that we have gone through over these years, as well as going beyond the traditional, I call them the kitchen sink fixes of, oh, go to the church, go to the barbershop. No, we do more structured interventions with trained professionals who understand our culture and our lived experience and understand what we face when we come into healthcare settings, as we were talking about earlier with the misogynoir as we experience as Black women.
Dr. Lopez-Littleton?
I know we're getting low on time, but I was just
No
gonna
worries, no
follow
worries.
up on what Dr. Sampson was saying. I think that, you know, as Black women, we're not a monolithic group. We, you know, have infiltrated most echelons of society. And so if you think about where we are and think about the work that we have to do, racial battle fatigue is a real thing. Because every day that I go to work, every day I exist in this Black body, and I exist in this society that doesn't necessarily respect or honor me in such a way that I don't have to think about my race. And so as we move forward with a society, we have to begin to think, how do we honor people? We're now using the word equity. And I think anytime academics get a hold of something, we shift the focus. So we've had structural racism, institutionalized racism, systemic racism. Now we're saying white supremacy, and it all means the same thing. It all means systems that are not designed to support diverse populations of folks. And so my challenge is, especially when it relates to mental health, there are so many stigmas, especially in the Black and Latino communities, about mental health and mental illness, that it's such a huge barrier to overcome in this regard. Talking about it within our families in such a way that it becomes real and meaningful and not something to be ashamed of. I've got a colleague who's running for Seminole County Commissioner, Pernell Bush, and he's a mental health counselor, and he's a Black male who's also a military veteran, and he's been beating this drum for so long in the community, trying to get Black people to get comfortable talking about mental health and their mental health status. And so it is one of the barriers that I think that as a Black community, and when I say Black community, I'm not talking about just impoverished communities. I'm talking about us as a people, like wherever we are, like even, you know, people who are professors or doctors or whatever, like we still have those same issues because it's not something that we've ever had to deal with when we were growing up, and even for generations before. We didn't talk about these things in a real way. We weren't able to see counselors. When something's wrong, we don't just, you know, we don't have a cousin or a friend or auntie or a mother who's gone to see a counselor. So when you don't have that, it's always an anomaly, and it's not something that you accept just as normal. And so as a society and as a Black community, we've just got a lot of education and a lot of growing to do in this regard. So thank you.
Cynthia, do you have any comments?
Thank you for including me, and it's been an honor. Yes, I can't thank the panelists as well as those that came enough. So I hope we continue to have these conversations, and yeah, I hope anyone can call on me. And I'm really very grateful that a section on democracy and social justice exists within ASPA. And I think all of those that have and do all of the hard work and continue to do so. So thank you.
Wonderful comments. I'd also just like to draw attention to just a few other comments we had in the chat. They'll be up there for a few more minutes. And also just to really amplify Dr. Sampson's point, I just want to mention that these issues are amplified with the added intersection of LGBTQIA. I would encourage everyone here to look at the research of Dr. Brownie Bless and Dr. Tia Gaynor, among a few others in particular on that. So with that, that is the event. We just want to say thank you to our amazing panelists, Dr. RaJade M. Berry-James, Cynthia Golembeski, Dr. Vanessa Lopez-Littleton, and Dr. Carla J. Sampson. Thank you to our wonderful audience. We in DSJ are not done. In a couple days, we're going to be announcing part 6 of Dismantling White Supremacy series. And that episode is going to focus on emergency and disaster management and preparedness. And as we end all of our webinars, we're going to end with this. As we go forward, let's remember it's our common responsibility to promote ethical, equitable, and just public service agencies, to name inequities, to understand the causes and effects of who or what is responsible, and to take action to promote just organizations so that all these agencies can fulfill the highest mandate of public service to improve people's lives. Let's dismantle these systems of racism and white supremacy to achieve justice for all and ethical public services for all. There's nothing more important. Thank you, everyone. Stay safe.